Hello and welcome to the final episode, the third episode of MedTable Talk, where we talk about all things CLL with two extraordinary scholars and leaders in the field. My name is Dr. Sanjay Juneja. I'm a hematologist, medical oncologist, chief of oncology at Baton Rouge General, which is also my hometown of Baton Rouge, and also known as the Onc Doc on social media. I'm super excited to have with us for the third time, and if you haven't caught the first two, you absolutely must. First, we have Dr. Nicole Lamana. Dr. Lamana, good to have you. Please let everybody know where you're from.
Thank you for having me again for our third episode, Sanjay. Columbia University Medical Center, CLL doc, clinical trial specialist in CLL.
Excellent. And also, we have Dr. Rampal. Dr. Rampal, good to have you.
Sanjay, good to be here with you and with Nicole. And I'm a hematologist at Memorial Sloan Kettering Cancer Center, focusing on lymphoid and myeloid leukemias.
Fantastic. But you all know that because you've watched the first two episodes very eagerly, right? Today, we're going to talk about the adverse events or toxicities that are a very important role for the oncology professionals when considering therapies, right? You can have good drugs that can work a long time, but you want to know what the trade off is with the toxicities and if there's anything you can do to decrease or mitigate them. We also want to focus on engaging patients of diverse backgrounds in discussing the risks of adverse effects relative to the treatment outcome. We have a special guest today that will talk to us specifically about mitigating those adverse events because she is very well versed on doing so. Christina, we're so excited to have you.
Hi, all. Thank you for having me. My name is Christina. I am a nurse practitioner at Columbia University Irving Medical Center. I work outpatient, mostly with indolent lymphoma and CLL patients.
Brilliant. So, Christina, when we talk and think about toxicities, it's not just this general list as, oh, these are all the things that can happen. You kind of want to group those different toxicities and have an idea of what to look for as it relates to each one. Can you kind of run us through on how you think about the different constellations or subgroups when it comes to side effects from treatments in CLL?
Yes, when we talk to these patients and we educate these patients, we really do have to consider all body systems. And we have to kind of match that with the known side effects of these medications. So if we talk about infections, for example, we know these patients are at risk for infections at baseline just because of their diagnosis. Now we're going to give them some kind of therapy and we're going to put them at an even higher risk of infection. So it's important that we let them know to notify their team as soon as they have any signs and symptoms of infection whatsoever. Cytopenias, we're going to watch for their blood counts to drop, right? They might become anemic or thrombocytopenic. They might develop neutropenia. So these are things we're constantly checking their lab work, and we can treat this with growth factor, etc. As far as gastrointestinal, we can talk to patients about the risk of nausea and vomiting, possibly diarrhea. And of course, there's things to mitigate these. Musculoskeletal, some of these drugs, when you start them, they can have joint pain, some muscle aches. So we can walk through patients how to manage that, either with some Tylenol or possibly if things are severe with some steroids. Rashes, any new therapy, there's a chance of a rash. Some of these, like the BTKs, we know that there's a risk of petechiae, which is just, broken capillaries more so than a rash, but we have to let patients know that these are possible. And fatigue, obviously a very common side effect. When you need treatment, you're more likely to be fatigued, but also when you initiate some of these medications, higher likelihood of fatigue.
I think that's specifically a good point, too, when you talk about infections. That's unique to patients with CLL because there's some intense chemo, you're immune sensitive and you can get sick, right? But the deceptive part, and sometimes to a fault, is patients with CLL don't necessarily look sick or look like they're at an infection risk. And that's why it's particularly important to educate because sometimes what looks like a simple rash, that may be infectious can quickly escalate depending on the organism. So, that kind of prophylactic treating can not just be with medications, but education. So when you look at like classes of special interest when it comes to effects with the specific drug regimens in CLL, can you give us kind of a walkthrough? Is there some kind of navigation besides the overlying one that you just mentioned that's specific to the kind of treatment mechanism or drug class?
Yeah, so we can look at some particular things that stand out in certain drug classes. So if you take the BTK inhibitors, right, you're going to think about the increased risk of bleeding. And patients are often concerned with the longer term possible side effects like hypertension or atrial fibrillation. If you look at the BCL2 inhibitors like venetoclax, for example, you worry about tumor lysis, and sometimes you think more about GI side effects. The anti-CD20s or the MABs, obinutuzumab, rituximab, you worry about infusion-related reactions. You worry about HBV reactivation. And as some of the others, like if you're talking about traditional chemotherapy, you worry about neutropenia and infections.
That's very helpful. So, Rajat and Nicole, what are the things that you're thinking about when you're going through the treatments? Obviously, you're thinking it by drug class. And what are some of the measures you can take to prevent it, ideally? And then, of course, what you do, if you recognize it.
Yeah, I think one of the things is the right drug for the right patient, right? And if you know some of the side effects, right, particularly cardiovascular side effects, or even the bleeding, you need to think about if a patient has certain comorbidities, is that the right treatment for them, right? Or disease factors. If somebody has really bulky disease, giving them venetoclax may put them at more risk than is needed. Where you might just be able to give them something like a BTK inhibitor instead. So trying to figure out the right treatment for the right patient is one thing. Second thing is, I think educating the patients thoroughly about what are the potential side effects so that they know what the warning signs are when they need to pick up the phone and, call the doctor about what's going on here, right? Atrial fibrillation is a good example again. Sometimes it's subclinical, but sometimes people present with palpitations and oftentimes palpitations are common and people ignore them. But in somebody who's recently started on a BTK inhibitor, that's something the patient has to know that they shouldn't ignore. They need to talk to their healthcare team about that. I think those are some of the major things in terms of trying to at least mitigate the risks of the treatments.
So here's a common community oncology question. But if somebody already has AFib, already getting anticoagulation for it, rate controlled, what should be their initial thought about something that may, quote unquote, cause AFib? Can it worsen the fib? Can it make RVR? Is it something you're pretty good, or relaxed about if they're already rate controlled? How should somebody navigate that?
Just to feed in a little bit, I think, certainly if somebody has some comorbidities that they're already being managed for, and then you're potentially going to give them a drug that could make things worse, it's a good idea to also loop in their other physician. CLL is a disease of older individuals. And there's no doubt that many of our patients have other comorbidities, hypertension, cardiac issues, renal insufficiency. A lot of these drugs can hit upon some of those areas. And so you want patients to be in very good control of their hypertension if possible. So looping in their primary care physician or their cardiologist that they're dealing with, that you might be starting an agent that could worsen those underlying issues will be helpful because then they can co-manage that with you. If they need to adjust their antihypertensive drugs, they got renal insufficiency. I mean, you're going to be sort of, modifying things accordingly. And as Rajit noted, you might select one drug versus another depending upon what their comorbidities are. They might need both of these great, wonderful agents during their lifetime. And so you're going to be dealing with their comorbidities anyway. And you're really going to be looking out for things that need modification if they're already on agents that they need to control blood pressure or cardiac issues. You're going to talk about whether or not can they be put on maybe a different anticoagulation agent if you're going to use a BTK inhibitor. So you're going to have to discuss all these things and loop in their other physician or get on board, a cardiologist to help with the management if there are issues that arise. And certainly you're going to counsel and educate the patient about all of these issues, and having a team, like having an NP like Christina, a pharmacist and other people to kind of go over this, because they're not going to understand all of this just at once. It's sort of, the process as you go through, the longer they're on some of these medications, the more they understand and get in tune with some of the potential side effects that they can have from some of these treatments.
And one quick rapid fire question, because I know it's important to community oncologists, arthralgias, otherwise known as bone pains. What is your strategy for that? Because it can be debilitating. What is the usual way of treating that?
Certainly, you have to make sure there's nothing else going on, right? You always want to think about that, but then you judiciously use analgesics as an adjunct to help with that. But in some cases, it's going to require either a dose reduction or a change in medication completely, right? And depending on the severity of that and its response to the more simpler measures, that's what you sometimes end up having to do.
We do try all these things,
Right.
don't get me wrong, but this is actually one of the more challenging side effects we have with the BTK inhibitors. And most people, it does go away. And so with some supportive measures, most of it does dissipate. But there's some individuals that's not the case, as Rajit was saying, and you dose reduce or you wind up holding the drug. We would try to exploit maybe one of the newer agents because there's some data for that. To see if it works, so that's less of a, that is a less severe grade. And if it goes away, wonderful, then that means you still can use the class. So I absolutely do try that. Certainly then if it doesn't and it recurs and it's problematic, then you're looking for switching the class altogether.
Yep, 100%. And I think this is what this slide goes through too, is also something you don't want in the community is when something is discontinued prematurely. But I think the overlying point is that it is very important to know what to do and how to de-escalate when these things happen, especially for grade 3, which generally we think of as, maybe requiring admission versus 1 and 2, which you can manage outpatient. So even in these circumstances, it looks like you can restart the BTK. And I think part of that kind of give and take is because they're so effective.
Absolutely.
Want to kind of elaborate with the neutropenia and tumor lysis that you may tell patients, specifically to look for, to let them know, their doctor knows so that they can treat it adequately?
As far as the neutropenia, education is key. You let the patient know this can happen. It is a possible side effect, and if it happens, we're going to handle it. So obviously, we can hold the drug. We can try to use some growth factor. We're definitely going to make sure that they are open and honest if there's any signs of infection. And of course, there's always an option for some prophylactic antibiotics. As far as the tumor lysis syndrome portion of it, again, constant education, encouraging a lot of oral hydration, making sure you're assessing the patient, you're checking labs as you should be, you're following up on those labs. A lot of these patients might need some extra IV hydration, and preventatively, you're always going to start like a hyperuricemic or other medications to help protect their kidneys.
I mean, a BTK is very easy. You could start a BTK. We don't really expect tumor lysis. It's very rare. So it's an easy drug to initiate, but venetoclax has some challenges, and depending upon the practice, your ability to get same day labs and then intervene on them if somebody has evidence of tumor lysis, you got to be able to hydrate your patient and do whatever additional that you might need to do is really important. And so patients who are high risk, you might want to consider, admitting into the inpatient hospital setting to get them through that initial hump, because you're starting with venetoclax, or even they're high risk and you're worried about giving them something like obinutuzumab because they're going to have an infusion related reaction to the obinutuzumab. So I think those are more challenging. I think the oral combinations will make this a lot easier, front loading the BTK. But in general, I think that this is probably one of the drugs that many local oncologists might shy away from a little bit because they may not have the ability to do same day labs.
That is very important. It really takes this kind of multidisciplinary, kind of collaborative approach. There's actually a very specific group that is looking at it both nationally and around the world of cardio-oncology. And so there are different pathways and guidelines, the first set of which was just released worldwide on the European guidelines to help assist not just with some of the BCA inhibitors, but all of those cardiotoxic drugs that you can either plug in to a protocol as even a general oncologist if you don't have that cardio-oncologist support in your academic center, or even as a specialist. So I think these are helpful to look through and resources we try to provide if you're somebody that has concern about having an underlying cardiac illness. So one of the key metrics that we always talk about is it's more aggressive when it presents, but then the question is, do we just catch it later? But are there disparities that kind of mirror what we see with breast cancer and prostate cancer relating to minorities groups specifically, Black population versus Caucasian? Or is that kind of relationship a little less correlated when it comes to treatment and treatment outcomes?
Sometimes we'll see if it's an issue because of the fact that there was not necessarily somebody who attended to their medical care. And sometimes that actually, can be seen in some of the underrepresented populations. And so when they present with complications from CLL, sometimes that's where I'll first meet them in the hospital because, they really didn't know and hadn't seen anybody and weren't really under medical attention. And then they're having a complication due to their underlying disease. And so that prevalence or severity of some of the issues can bear itself out that way. Do I think there's anything specific in general? No, with the exception again is clearly we know that if patients have a higher incidence of other comorbidities because of their ethnicity, right? So hypertension increased in the Black population or something like that, then certainly you're going to be more attuned to that when you might give them a certain treatment because then you're going to be, you may need to adjust their antihypertensive or again, sort of be a lot more proactive and have a primary care internist or a cardiologist be on board with that because, that inherently might be different. In CLL, obviously, it is not as common in patients of underrepresented minority backgrounds. So it's, it's typically more of a Western European descent. So we see a lot less Asians, Black populations with CLL. Not to say we don't see any, but the point is they're definitely a smaller portion of the pie in CLL specifically. But you'd be in tune with again, whether or not their general medical care is well attended to or not, so that you can intervene accordingly.
I completely agree with your point, right? Because the thing is, if just because somebody's never been diagnosed with heart disease or hypertension doesn't mean they don't have heart disease or hypertension, right? And that is an access issue. And then getting back to your earlier point, right, about venetoclax, right? Somebody giving venetoclax has to be done in a properly resourced environment, right? And then if somebody is in a healthcare setting where they don't have access to same-day labs, as an example, right, it makes it harder and potentially, prevent uptake of the medication, if you don't have the right resources to administer it safely. So those are, I think, the considerations that I would have in this particular realm.
And so we've mentioned this before, but it's particularly important and relevant when it comes to side effects, because that is almost a purely like symptomatically based dialogue, right, between patient and care provider. Whereas a lot of things, of course, can be assessed on the lab work. You don't know to get the lab work unless there's some kind of communication to say, hey, I have a fever. Oh, are you neutral? And that is usually, arguably, much like cancer, the most important thing, catching it early. If you can catch something early, you get into less trouble than catching it late. Again, the education piece, you have to be educated. You have to take the time to educate on saying, these are the things of relevance to me. This is how we identify them. You have to have the communication from the patient. But again, I think it always falls on the responsibility of the oncology team to make sure that they are enabled with the tools.
I think there's also, where kind of proactive communication makes a difference, right? So within the first days to weeks of treatment, what sometimes we've found to be useful is just having our clinic nurse just call the patient just to check in, right? Just not a formal visit, just what's going on, how are you doing? Sometimes people don't want to feel like they're bothering the office with a complaint that they think is minor, but that minor problem is going to turn into a major problem if we don't do something.
You nailed it. And also, some patients may be afraid to talk about a symptom because they don't want to be discontinued. You talk about the big hype, you're like, this regimen is great. The data was great in 2022. I'm excited. And then you're afraid that if you bring something up and it's a grounds for discontinuation, that you'll be tabling a therapy when really you should just put up with it. So it's actually, there's multiple layers to that concept of wanting to feel comfortable and visible about sharing these things.
Yeah, it's just my nursing cuddly side. And as Dr. Rampal said, a nurse checking in is wonderful. I know a lot of facilities might not have the resources for that. So it's just as important that you encourage the patients to feel comfortable contacting you. And if they have a question, concern, our reinforcement and our re-education can help extend their time on drug or appease their worries.
Well, Christina, thank you so much for sharing all your wisdom and not just that, but everything you're doing every day. Thank you so much for that.
Thank you, everyone.
And so for our last and final episode, when it comes to toxicities, if you could change one thing in a perfect world about things that relate to those toxicities with treatments, what would it be? Dr. Rumble?
To me, it still comes down to communication, right? And again, educating the patient about the potential toxicities, educating about when you need to call, and then trying to emphasize from the provider side of things to be proactive about communication. Don't wait for somebody to call, particularly in the early phase of starting a treatment, but be proactive about reaching out to the patient.
Very good point.
Yeah. I'm in agreement. I think that these medicines are great and they're not going to go anywhere. The class of BTK inhibitors and venetoclax, the BCL2 inhibitors, of which more are being evaluated, are going to be a mainstay of treatment for CLL for a really long time because of how wonderful these treatments are. And it's really, really, really important to make sure that we can sort of mitigate for some of the adverse events that we're seeing with some of these therapies so that patients can stay on therapies. That, as you noted earlier, that we can sort of continue or exploit a class as long as possible before needing an alternative therapy, because we know this is a chronic disease and they need to be on potentially multiple therapies during the course of their lifetime along their CLL journey. So it's really important to have a very good foundation and how to manage the side effects. When we talked about chemoimmunotherapy earlier, I think one of the issues about why chemoimmunotherapy is still being given in many practices is because they're just used to how those medicines work for their lymphoma patients. and then getting used to some of these newer agents and learning how to mitigate between the adverse events isn't as commonplace if they're not seeing as many of CLL patients in general. So if you get accustomed to using these medications and learning how to tweak some of the nuances about the adverse events, and then absolutely educating the patients, as Christina alluded to, then having that dialogue that they can reach out, being able to have that open dialogue, because then you can get them through their side effects and they can move on with their therapy. So very, very important.
It's just so important. Yeah. For myself from the community end, it's more of an issue to just have the specialist and this kind of like multi-specialty, multidisciplinary approach. Sometimes cardiologists are so saturated it takes months to see them, but we need to really utilize all of the technology that we have to just bring those specialists and that kind of multidisciplinary collaborative approach to handling some of these toxicities, because a patient deserves that kind of full attention. So
yep. The other thing that people can do, and they don't realize this too, is that if they're unfamiliar with using some of these medicines, oftentimes reaching out to, a person who, like Rajit and I, who do this all the time, sometimes we'll help them by starting the therapy on their patient, getting them through that beginning part of their adverse events, particularly with venetoclax. And then when they're stable and on a stable dose and there's no more tumor lysis to be worried about, they go back to their local oncologist who could just continue their oral therapy, and it's not a problem.
Right.
Surgeons and physicians should take avail of the fact that there are people who do this all the time, and they could use these really great therapies. But if they're not sure, they should reach out to somebody who does.
With all that said, thank you all so much for participating through our Med Table Talk on CLL. 3 episodes. We hope you watch all of them. We have a bunch of fun. If you have made it to the end, which you have because you're here, we do have credit for you to be able to earn just by completing the post-test and evaluation. I have been very humbled to be with you, Dr. Nicole and Dr. Rajit, for everything and all the wisdom you've taught us. And we really appreciate everything you're doing.
Thank you for having us.
Yeah.
Pleasure to be here.
All right. Brilliant.